Happy New Year. I hope we hope that you had a good break. So welcome to the first CAFE seminar of 2021. So today we're very pleased that Nicola Gennaioli from Bocconi will be presenting his paper entitled "Older People Are Less Pessimistic About the Health Risks of COVID-19." And it's joined with Pedro, Bordalo, Katie Coffman, and Andrei Shleifer. And we are also delighted that Rawley Heimer from Boston College will be giving the discussion. So as usual, there will be 40 minutes for the presentation, 20 minutes for the discussion, and 15 minutes for Q&As. Nicola, the screen is yours.
Thanks a lot, Laurent. It's a pleasure to be here. Thanks for inviting me. And sorry to everybody to bring your attention to this doom topic that has been distressing us for the last 1 year now. As analysts of beliefs and belief formation, with Pedro, Katie, and Andrei, we thought that we could not kind of miss this opportunity to see, how belief formation about COVID-19 works, in a representative sample, in this case of the US population. We thought this was interesting is because relative to many events about which we routinely measure beliefs, here we have, a major, unprecedented, this type of, pandemic shocks, especially in the Western world, are a very rare event and life-threatening shock. So we thought that, all the, so to speak, characteristics were there so as to allow us to uncover interesting findings, potentially also relevant for policy. And so we decided to conduct 3 online surveys. Each survey covers 1,500 US residents. During the first one was in May. It took us a little bit to react to the shock. The second one has been held in the summer, end of July, early August. And the third and last one, and we will not do more survey on this, has been completed in November of 2020. And this is a paper that it's not even a paper yet. What my discussant has read is a piece, put on NBR because, many people were working together on this topic, and we unveiled a finding that we thought was interesting. That's why we decided to rush to put it out there. But this, it's very preliminary. I mean, it's not even a completed research paper, and we're kind of trying to take stock of the results, the wealth of data. The third survey just came in, and we now are going to analyze all the data together. Here, I am mostly going to report the results of the first survey, May 2020. I will also show some basic facts about all the 3 surveys together. And then I will conclude at the end by bringing, a glimpse of the sort of themes that emerge also from the third survey, because along the way we learned a great deal of what measurements could be interesting, and so we reached the set of outcomes that we have. So what are the preliminary findings that I'm going to talk about today? First is that, when we were thinking, about this event, thought, look, all cards are in to see like a massive overreaction of beliefs. I mean, it's true that, you know, there has been quite a lot of discussion in the media about, you know, possible estimates of fatality rate COVID, but, you know, there is also like an intuitive action of people. We know that people don't take statistics into account to the full extent that may be deserved, and we thought, okay, you know, mass media exposure, highly salient event, we are going to see massive overreaction. One of the findings is that this is not the case in our data. If you look at average estimates or, you know, measures of average estimated risk of dying conditional on contracting COVID, that's the outcome for which I think, you know, there are objective estimates that are more reliable relative to others like infection rate, etc. We don't see on average a massive overestimation. We see a little bit, you know, it's not dramatic. What is dramatic, and this is something that we didn't expect, this is kind of striking fact upon which the title of the note is built, is that we find that young people are much more pessimistic, okay, than the elderly. And they're more pessimistic in general, in the sense that they are more pessimistic about the average infection rate of people, the average, rate of death of people, but they're also more pessimistic about themselves than the elderly are pessimistic about themselves of dying conditional on infection. So kind of the risk assessment goes the opposite way, and we will see in a dramatic form what the epidemiological literature has taught us. The third finding is that this relationship between age and risk perception is not only present in COVID, it's also present with a very similar gradient in other non-COVID health hazards. So we measured also the extent to which people think that they are subject to risk of death for non-COVID reasons and, you know, of diseases. And we find that even there, the young tend to be more pessimistic than the elderly. But on the other hand, the young are not more pessimistic than the elderly when it comes about the economy. So it seems that it is not so much that the young are generally more pessimistic than the elderly, you know, across the board. When it comes to the economy, they are not. When it comes to COVID and non-COVID health reasons, they are, okay? And so, you know, as you'll see, the type of interpretation that we give on the basis of this preliminary analysis is that, I mean, one possibility is that kind of the young, for reasons that we currently don't fully understand, are more impressionable and more impressionable perhaps to the shock provided by this pandemic, and this might render the circumstance of health risk very salient for them, not only with respect to COVID, but also non-COVID hazards. We also document, and this is the part that I will show you from the recent survey, you know, once we now have 3 waves and we have, you know, a representative sample of respondents from 50 states, US states, we can try to link the dynamics of beliefs about COVID at the state level to the dynamics of cases at the state level. And, you know, the last piece of data we'll show you is that beliefs about COVID health risk, which I will explain we measure become more pessimistic when there is a surge in local new cases, a new death in particular, but it also works through the number of infected people. And also when individuals have personal COVID experience, when they know someone who has been affected by COVID or who has died from COVID. Now, what is this contributing to? You know, there is a large literature in psychology and in behavioral economics, whereby people do not treat all, you know, events, uncertain events, in the way that we would think rational agents think about these events. And in particular, Kahneman and Tversky proposed, building on earlier results in psychology, that, you know, individuals tend to exaggerate the probability of unlikely events and tend to underestimate the probability or underweight the probability of a likely event. In a sense, if you think of, you know, correct beliefs as being, you know, a 45-degree line relationship between the truth and what the individual believes, you know, the Tversky and Kahneman idea is that the probability weights are too flat. You know, they tend to be above the 45-degree line for low true probability and below it for high true probability. Now, what we find here is very different. I mean, we find an inversion. I mean, we find, you know, and I will return to that, that the young who have the low probability, you know, events with respect to themselves, they do not just compress it toward that of the elderly, but they kind of overshoot it. And there is work by Lichtenstein and others. It's a famous paper, and it's also about the causes of death. And we find that, and I will show some data from that paper, that there are domains, or with respect to assessing the causes of death, people tend to have these flat curves as the Kahneman and Tversky probability weighting function. And then they also show that people tend to exaggerate, you know, unlikely cause of death, provided that they are memorable or salient. And kind of some of the result that we are building up, like the idea that when there is, you know, more cases in a state, then, you know, COVID risks become more salient and people become more pessimistic, are in line with this older paper as well. But what we show here, which is new and we think interesting, is that the age gradient is key. So the key thing here, the key novelty here, is really this heterogeneity across different age group. And so the question, we have scratched the surface, we need to study the coming months, is what is the driver of this age gradient. You know, one could be that, you know, death is more salient or more surprising for the young who are less adapted to this type of risk. So they might react more strongly when they are prompted to take it into account, relative to the elderly who might have, you know, already formed the idea through personal experiences, for instance, that death might be actually, you know, common. But it might also be due to the fact that the young consume more or different types of news and interact in social media. And that might be an age-specific channel of salience, of availability, that might be responsible for the type of effect we find, even though one has to take into account that the decision to acquire information is endogenous. Something else. And we are trying to measure in new surveys also media consumption, try to assess. What's the broad theme here? You know, I think that the broad theme of this is the idea that, you know, we see that, you know, socioeconomic characteristics affect beliefs. They help explain beliefs in many measured surveys. Any survey you take, you know, shows amazing heterogeneity in beliefs, you know, among people, even with respect to events that are, you know, very common. I mean, we have this recent paper with Pedro, Andrei, and Grandma, in which, you know, we have data from professional forecasters forecasting the GDP growth in the United States, inflation, etc. You know, these are like this common variable, you know, they often use models where you would expect a lot of agreement, and instead you find a lot of disagreement there. So the question is, you know, what's underlying this heterogeneity? And one thing that we hope to assess using this data is whether this heterogeneity might be driven by, you know, personal characteristics such as age, through the effect of memories, of experiences, of, you know, or of, you know, the level of surprise that a certain event might impact. So what's the structure of the survey? We have a representative or close to representative sample of the US population, 50% female and the rest male, ages, you know, one quarter is between 18 and 34, another quarter is between 35 and 49, and then it's a bit tilted relative to the actual population distribution on the 70 years and older, because, you know, we thought that these were most of the action would be at play, and we just didn't want to undersample this group. Household income, like broadly representative, of course, you know, we did this through Qualtrics. You know, I was amazed that we were able to find 30% of people who make more than 100K a year that respond to this survey on Qualtrics. You know, representative sample also geographically and with respect to racial composition. One thing that we kind of worked hard to in designing the survey was to ensure thoughtfulness and foster accuracy. I think this is important because, you know, if you think about people making decisions and harnessing their beliefs to make decisions, yes, sure, part of the belief formation will be driven by intuition, but also, you know, people kind of think, and we didn't want them to casually give numerical answers without understanding well the meaning of these numbers. So we put through the survey, and I will not bore you with the details, many attention checks, but we also asked the questions in terms of frequency, not probability. So the way we measure infection or death rates is by asking how many out of 1,000 people. And in psychology, it has been found that once you ask questions in terms of frequencies, it's not that the biases go away, but they get moderated. We also train subjects to use these frequencies. So we have some questions where we warm up what it means to use frequencies and to convert them into percentages. So, you know, if 10 out of 1,000, it's 1%, you know, and you have them go back and forth to get some experience about that. And then we ask a question about the frequency of red-haired Americans, which allows us to assess the general tendency of subjects overestimating frequency. So one might be worried that maybe there is something that induces some people just numerically to give higher number to infrequent event. And here we ask on a totally unrelated domain, which is, you know, the frequency of red-haired Americans, you know, this, and so that we can control. What are the measures of beliefs that we elicit? Beliefs about yourself, Okay, and I will make it now clear what beliefs about yourself are. These involve the risk of infection. Infection when? In an horizon, which is 9 weeks, which is roughly the spacing from one survey to the other. Then we ask the risk of hospitalization conditional on infection. And finally, we ask the risk of death conditional on infection for yourself. Okay, these are what we call belief about selves on COVID risks. The second set of measures is belief about other health risks for yourself. So it's again yourself, your health risk, but here you have hospitalization for non-COVID reason, we have death for non-COVID reason, we have heart attack, we have cancer over the next 5 years, okay? Because these are, you know, infrequent enough events that we don't want, especially for the younger population, that, you know, we give a longer horizon to have, you know, kind of a better sense. The third outcome that we measure is beliefs about economic risks and individual perception of stock market booms or collapses and unemployment surges or reductions. And then, and that's an important measurement at the end, is beliefs about COVID risk for others, not for yourself, but we ask you to give the probability of death conditional on COVID infection for different groups. Different groups in society means different age categories, different racial groups, different gender groups. So when you have to come up in this survey, when it comes to COVID, both for your own risk and for the risk you think, you know, general population-wise group members face. Then we ask a lot of socio-economic and health information of respondents. You know, we had learned that COVID, it's more risky for people whose health is more vulnerable. So asking for health conditions seems important. And we also ask preferences about lockdown policies and individual behavior. And we vary the sequence of questions. One thing that we can do by varying the sequence of question is to see whether there are priming effects. For instance, if I ask you to first think about the COVID risk for the general population, does that influence how you think about yourself? This is again something that we plan to explore, but you know, I will not show results today. In waves 2 and 3, we also ask, you know, we ask many other questions, including political leaning, because, you know, we learned that politics is everywhere and also in COVID. So we asked about political preferences and importantly, media consumption, social media use, etc. But I will not talk about this today. I will say a little bit. I will show some results with respect. Here is the belief elicitation. Beliefs about self. How do we have you assess the COVID risk for yourself? Question, think about 1,000 people very similar to you in terms of age, gender, race, socioeconomic status, zip code, health status, etc. So we don't ask about really yourself, but someone in all respects similar to you. So think about these 1,000 people who contract COVID in the next 9 weeks. Please enter how many of those 1,000 people who contract COVID-19 will pass away due to it. Okay? That's the risk of death for you. Instead, we ask about beliefs, and of course, the same format holds for the risk of infection and the risk of hospitalization conditional on infection. Then, as I said, we also ask you beliefs about the risk of others and with respect to different partitions of society. And here consider the age partition. So we ask, think about 1,000 people in each of the following age categories who contract COVID-19 in the next 9 weeks. How many of those 1,000 American do you believe will pass away from COVID-19 in the next 9 weeks? So if it's age, we have 3 categories. You will see what these categories are. And for each category, you have to report how many out of 1,000 in that category will die if they contract COVID, how many of the 1,000 in the other 2 categories respectively die if they contract COVID. And so let me then go to the facts. First, beliefs of COVID outcomes for oneself, okay? That was the first question I showed you. So here you see 3 outcomes. This is, here we're using medians. I mean, we're really trying hard to avoid crazy answers, outliers, etc. Okay? So we look at medians, and here we have the median estimated risk of infection in the next 9 weeks. Then here we have the median estimated risk of hospitalization conditional on COVID. And finally, the median estimated risk of death conditional on COVID. The blue bars are respondents, the youngest, between 18 and 34 years old. The orange bars are the next youngest, 35 to 49. The gray from 50 to 69. And the yellow are the oldest, 70 and older. And so what you see here is that the young think they have the highest probability of contracting COVID in the next 9 weeks. They think that, 90 out of 1,000 will get COVID, almost 10% will get COVID in the next 10 weeks. And then there is a declining age gradient. And you would think, well, because the young are more interactive, go out, etc., so this is fine. But when you get to hospitalization conditional on contracting COVID, you see again this declining path, which is the young are significantly more likely, or believe significantly more likely to be hospitalized conditional on COVID than the elderly. And the same is true with respect to death. You see, the young, the blue bar, estimates that 20 out of 1,000, roughly 2% of them will die if they are infected from COVID, whereas people 70 years or older, they attach a probability of 1%. And again, these are median estimates. So there is this age decline. What do existing epidemiological estimates suggest? Well, that if you look at the overall population, the infection fatality rate is around 0.6%. Now, someone might say 0.3, someone might say 1%. Here, that's not the, these are differences that are very small in the scheme of things we are talking here, because there is a sharp age gradient in them. And I mean, we've seen it in the news, and that's been reflected also. I mean, it's consistent with the estimates of epidemiologists. In the youngest age group that we have, the infection fatality rate is about 0.2%. That's like a consensus estimate. The numbers we saw means that the young overestimate 10 times. I mean, give an estimate that's 2%, 10 times that. Likewise, the infection fatality rate is between 5 and 10% for people who are 70 or plus year old. And we saw that, they tend to give roughly 1%, which is between 5 and 10 times lower than the actual. The beliefs of the median respondent instead are kind of consistent with, you know, and we compute it using beliefs about others. What people believe is that the average fatality rate is between 1 and 2%. It's a bit above these and other numbers, but it's not dramatic. What is dramatic here, the striking fact, is the age gradient. That's a finding from the 1978 Liechtenstein Slovich Fiskov paper. Here is the true frequency of causes of death, and these are averages on the y-axis of median responses about the same, the frequency of the same causes of death. And then they fit a curve that relative to the 45-degree line, which is, you know, if you want rational expectation, the curve is flatter. And so you overestimate the probability of dying for, you know, unlikely events like botulism or a tornado, and then you underestimate the probability of dying for things like heart disease or a stroke. Now, you could think that the youngs are here, they have low objective probability, so they overestimate relative to the truth, and the elderly are here, they have high objective probability and they underestimate relative to the truth. But you see the line, although flatter than the 45 degrees, it's increasing. Instead, what we find is the decreasing. That's like what happens if we ask, when we look at what people believe about others, are young people only pessimistic about themselves, or they are also more pessimistic about the population as a whole? These are estimates for the believed probability of death in these age categories: under 40, thank you, Laurent, between 40 and 69, and 70-year-old and older. Again, the blue are the young. Now, the orange, the middle, the orange and gray, the middle, and the elderly are the yellow. Now, what's interesting about this is that within each respondent group, the gradient is increasing. So everyone believes that the elderly are more exposed than the young. But again, and consistent with the previous thing, you know, the young are much more pessimistic than the middle-aged and the elderly. You see the blue bar are way above. So the young are more pessimistic about COVID in general than everybody else, and they are more pessimistic about their own COVID risk, I would say, as a consequence. This is using all three waves, okay? And, you know, this is COVID risks for self, and this is COVID mortality risk for others. Again, the patterns are the same. Now, we can say, okay, what if you throw some control? There are many things that you're measuring, many socioeconomic and health factors. So how does this look like? Well, here I have, you know, many more controls in this table if you look at the paper, but I could not put all of them, they wouldn't fit. So I've only put in this presentation those that, you know, have more explanatory power. Now, this is respondent age, you know, sharply negative and highly significant statistical association with assessment of COVID risks. Also conditioning on income, and income tends to make you more optimistic. On education, more educated people look more pessimistic about their own vulnerability to COVID. People who have serious health conditions, have been hospitalized, are also more pessimistic. And also people who have a family member hospitalized are more pessimistic. And here you see the rather estimate, okay? This tendency to give high numbers is indeed quite predictive of these beliefs. But once you control for all these things, the age effect, this age gradient, you know, is still highly robust and statistically significant. At this moment in which we took the survey, we could not control for political affiliation, etc. So we devised a way to kind of check for that. Control for the average assessed risk for others. Here you're asking, questions about self-exposure, but we control for what you believe is the exposure of others. And we thought if you're Trumpian, you tell a smaller number than if you are a Democrat. And indeed, once you control for this, you see that there is a strong positive association between risk perception for yourself and those you hold for others, but even after controlling, the age effects are smaller, but they are still significant. This finding is present also in other studies, at the same time, different measurements of beliefs for COVID has been taken. One was by Belot and others for several countries. They find much more outlandish belief and probably don't measure with all the checks and frequency we did, but they also find, we find using their data, is a strong age gradient. You can think about politics. Now we have the data, we can control directly for politics. And, politics is not really that powerful in terms of explaining, politics might be absorbed in part by age because there might be a allocation to different parties on the basis of age, but the really strong effect comes from age and not for politics. So bottom line, large heterogeneity in beliefs about COVID risks for self and others. And there are two main drivers. One is age and another is experiences and health conditions. This is true also for beliefs about others and the fact that your own experiences affect the beliefs of the risk that you have about others, presumably reflect availability in mind of COVID risks. So that, if maybe you have bad health experience that makes you more pessimistic about your own health in general, once you think about the health of others, you project that into them, and so you're more pessimistic about them as well. Other risks not COVID-related. Here is the risk of non-COVID hospitalization in the next 5 years, non-COVID death, heart attack, and cancer in the next 5 years. If you regress it just on respondent age, conditioning on the previous control, you see this negative gradient for hospitalization and non-COVID death, where you don't see any gradient for heart attack and cancer. After you control for your own risk of COVID death, and the COVID pessimism about others, what you see is strong positive coefficients here. What do these coefficients mean? That people who are paranoid about COVID are paranoid about their own health as well. There is kind of a common factor driving, your health pessimism. And once you net out the common factor that drives health pessimism, you see that age start getting a positive sign. You see? So older people are indeed more at risk, and they report higher risk, as you see here, 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 and here not significantly so, but only after you control for the common factor of health pessimism that influences COVID beliefs and influences other health risks. If you do it for economic risks and you ask, will the stock market go down, go up, or will unemployment go down or go up, in the next 9 weeks, we see that the respondent age is very inconsistent in terms of effect, hardly significant, and sometimes in one direction, sometimes in the other direction. And the COVID beliefs are essentially irrelevant for assessing economic risks. So it's really about the fact that there is this factor of health risks that makes the young more pessimistic about COVID and more pessimistic about other health risks, but leaves the economic domain unaffected. One way in which one can think about this, how to rationalize this, is the possibility that the COVID shock makes the prospect of death, of disease, particularly salient for the young, who are not accustomed to think about these aspects. And because of that, they induce them to overestimate these risks across the board, but in a way that does not spill over to economic risks that are risks of a totally different sort. I want to conclude with this last slide. Risk perception and 1 month death growth in the states that experience higher growth of COVID deaths in the last month see more pessimism, both about oneself and about others with respect to COVID risk. And one thing that we would like to understand here is whether this is only on the way up to the curve or whether beliefs deflate as you go down the curve. And we have enough variation to ask that. Punchline, what does this preliminary look at the data suggest? First, local salience of disease and that, we saw it in the last thing, matters for risk perception. That, COVID perception and health risk perception are intimately related and maybe they influence each other. And there is a strong age-related heterogeneity that might be explained by the effect of surprise or by the effect of experience, media exposure, etc. We hope with this to shed light on belief heterogeneity about these important events, but hopefully not. Thank you.
Thank you, Nicola. It was very clear and interesting presentation. So the discussant is Rawley Heimer from Boston College.
Thank you so much for asking me to discuss this very interesting paper. And thank you, Nicola, for giving a great presentation that made it so clear. I wanted to say, first of all, that I thought that one of the reasons why I was asked to discuss this paper was because I have a few related works on mortality beliefs, but I've come to learn that it probably is because I'm a redheaded American and I'm a quality control check in Nicola's survey. And it seems to be a very important factor within their survey as well. But I want to give a couple of disclaimers before going on to my thoughts on the paper. As Nicola also pointed out in his first slide, that this is a preliminary paper. The paper is very much a work in progress, and it's actually very fun for a discussant. So it gives you sort of a blank canvas to throw your ideas out there, because you know that the paper is going to go through a few changes in the future revisions. And so in doing so, I noticed that Nicola already plans to have adopt some of the ideas here. So that I'm going to propose. And so I think that this will be useful background for them as they go forward. The other disclaimer is that as I shamelessly reference my own work, I do so pretty frequently, but there's a pretty tight connection between some things that I've done in the past. So that should help you sort of understand the background of my thoughts on this. And Nicola is very kind in their paper and also citing our work too. So it's not a criticism of them, it's sort of just to give you, the audience, a little bit more background. Okay, so when I was reading through this and putting together these slides, I wanted to find a quote that said, that's explained why beliefs are really important. And the main reason why beliefs are really important is that they often translate into actions. But instead, I found this really great quote that I actually think summarizes our current moment. And it says that we are the only mammals that can cooperate with numerous strangers, because only we can invent fictional stories, spread them around, and convince millions of others to believe them. And so I think that this is something that explains a lot of phenomenon that's going on today, both in terms of the political environment, but also especially something that's been important for COVID. And so an example of this that it comes to mind for me when I think about the COVID moment and the way that this has transpired in the US is the Sturgis motorcycle rally. So this is in a small town in South Dakota. It's a gathering of, in some years, a million motorcycle enthusiasts. And they get together and every single year, and they did, I used to live up in this part of the country too. I didn't attend these rallies, but I did. Was. But I did see the parades of motorcyclists going to attend it, and it was a really big event, and it attracted a lot of media coverage, in part because people just completely ignored any of the mask wearing requirements and other sort of mitigating policies that might have been put in place. And so you can see here that this is very close to Mount Rushmore, which is a famous monument in the US. And you can see clearly that people are just walking around without masks, even though that's, there's very little cost to putting a mask on, and it has the potential to save a lot of lives. So that you have this huge gathering of people that have basically just completely are either ignored or ignorant of the best practices in terms of handling the pandemic. And so this has had a really big economic effect. And so this study has, by several authors in epidemiology, have looked at the effects of this, and they found that in Montana, in Meade County, where this is located, in South Dakota, I was in Montana, in Meade County, where this was located, and in the state of South Dakota more generally, there was a really big increase in COVID cases. But it didn't just extend to South Dakota. It transpired and had a big effects around the country, right? Because you had people traveling from all over. And so what they were able to do is track the areas that had the largest population inflows to South Dakota during the rally, and it helped spread transmission by an estimated 6.4 to 12.5% increases in cases around the country. And so this has been sort of the story of the US. The US has done a really bad job in terms of handling the pandemic. This statistic, I think, is one of the most fascinating statistics, and one that we're going to have to study for many years to come. The United States makes up 4% of the world population, but 20% of COVID deaths. It's just absolutely astonishing. And you might think, all right, well, the US has been really spectacularly terrible at implementing policies, but I don't necessarily think that that's true. I mean, a lot of states have done a pretty good job of trying to set mask mandates and try to lock down. But here's a quote from the Sturgis mayor at the time, who said, "I said back in March, do you want me to build a wall around Sturgis or a wall around South Dakota? Because that is the only way we could have stopped them," right? And so the story and the punchline from this is that there's no amount of policy making that anyone in the US could have had if you have this mass of people with incredibly inaccurate beliefs about whether or not they should be attending a motorcycle rally. And you see this in other domains as well. For example, you've heard about these stories of people who are refusing to put on masks when they fly in the US. And so Delta has banned some 350 passengers for refusing to wear masks during flights, and is adding 100 people a month to its no-fly list. I mean, it's a really simple action that people can take, and people are refusing to abide by the rules. And so it turns out that this is not a phenomenon that is isolated today. We can look at misinformation about infectious disease. It plays an important role in many past crises of the like. So, for example, we have the current anti-vaccine moment is prominent in the US, and I also understand that it's prominent in other countries as well. There was a lot of misinformation about Ebola transmission in West Africa. And the bubonic plague in Europe, for hundreds of years was fraught with lots of inaccuracies about the pandemic, and they had huge consequences. So, for example, there was mass killings of Jews just because of the belief that they were responsible for the bubonic plague. So let me so showing that these beliefs are really important, I'm really happy that Nicola and his co-authors decided to take this on, because I think that understanding how people form beliefs about COVID-19 is probably the most important question that we have regarding the pandemic. And so their main finding, and this is the one I'll focus on a lot today, and when I get to more details in my talk, is that the perceived health risks associated with COVID-19 falls sharply with age. And so here's the main figure in their paper. And so my main suggestion for the paper is to work with these other surveys and to really dig deep and try to understand the mechanisms behind this. And this is what the authors are trying to work on in the coming waves of the survey. And I have a few questions about where this might be coming from. And I think that the authors are already sort of thinking about these things to begin with, but I'll give a little background for the audience to more generally. And so these questions are broadly thought about in terms of what are the sources of information that people have across ages? How does the salience of the COVID differ across ages? And also I want to talk a little bit about overconfidence bias, because I did a little bit of related work on this early during the pandemic period. So I'm gonna run through some discussion about where people might be getting information. And so one of the things that I think has been really striking, finding in general, and this is just not related to COVID-19 at all, is that old people tend to actually be really susceptible to misinformation. They have a lot of trouble understanding what is a credible news source, what is not a credible news source. And Facebook has been a pretty big, perpetrator of this. And so here's a figure from Science Advances that shows that the number of fake news stories that are passed along by older individuals is much larger than that of younger individuals. So for some reason, younger individuals are actually seem to be capable of determining what is real and what is not, whereas older people tend to be very miscalibrated about this part. And you can look, and I gather that the authors are probably going to try to do something like this. Here's a picture from the State of the Nation, a 50-state COVID-19 survey that has authors from a number of top universities and from medical teams. And it looks that basically there's a huge range of ways in which people are getting misperceptions. And so a lot of them are related to social media websites, which of course is one place where we think that there's a lot of misinformation spread. But even traditional news websites has been culpable of this as well. And there's also just misunderstanding of various factual news. So for example, you might see that things that you might think that are more accurate, like print newspapers, and local television, these things are still people might misinterpret the types of news that they get from them. And so the next question is can we connect these can we connect the news sources of news that people have to their actual beliefs about COVID in a way that's that is sort of causal? And there's a paper that made a lot of attention at the beginning of the pandemic that I think is worth referencing here, because it's a really incredible paper. It's called Misinformation During the Pandemic. And what they do, and the authors do in this paper, is they ask how seriously people treated COVID. And they have a number of metrics of this. And the main thing that they do is they study differences between viewers of two Fox News programs, the two headlining nighttime news programs that they have, Tucker Carlson versus Sean Hannity. And what they find is that Carlson was actually was on top of it with COVID, whereas Hannity wanted to downplay the virus as much as possible. And so they look across episodes and see who is mentioning COVID, who is taking it seriously, and Tucker Carlson is taking it much more seriously than Sean Hannity. And what they find is that they show that there's this really big difference in timing of when people change their behaviors about COVID, related to the propensity that people had to be looking at Tucker Carlson's show versus the Sean Hannity program. And so any efforts to try to connect these to actions, I think would be really remarkable. And if it's possible for the authors to do that, I think that would be great. And so my suggestion, and this is Nicola's already sort of going at this, is to ask respondents their sources of information. And I wouldn't just extend this to different types of news sources. I would ask about friends and family, official sources, whether or not people are forming their beliefs based on their gut feelings or intuition. But I want to say that the one thing that sort of stands out to me that is a little bit feels a little bit hard to reconcile is that if old people are so more susceptible to misinformation, but they seem a little bit more calibrated, it seems a little bit that seems like a little bit of a puzzle to me. And so I would encourage the authors to think about that. The next thing that I wanted to talk about is salience and miscalibrated beliefs. And so I've worked on this in a paper that was published last year or actually now it's 2 years ago, in the Journal of Finance. And so myself and my co-authors, we studied the effects of mortality beliefs, and we were asking questions about how it affects life cycle consumption, savings choices, and other financial decisions. And here's what we did in the paper. And so we were motivated by this figure in part, and this is, I should have mentioned that this is from the Survey of Consumer Finances. And this is a very consistent picture that you'll find in it. And what I'm showing here is that these darker bars are subjective longevity. So these are people's stated responses about how long they think they're going to live, versus the objective longevity that are posted on the CDC website. And so here you'll find that there's this really interesting age gradient pattern that's pretty much consistent with the findings of the authors, where the young tend to underestimate their longevity, whereas the old actually overestimate their longevity. And this is true across genders, even though that there's a little bit of a level difference in the bias between male and females. And here's what we did in the paper to try to understand where this bias comes from. And I would encourage the authors to do something similar to this. And so what we did is we asked respondents, when they gave their answers for how long they think they're going to live, we asked them what factors came to mind. So this is pretty free form, but we asked them to put a weight, and the weights did not have to sum to 1, but we allowed them to say, whether or not they thought about the natural course of aging, medical conditions, and a variety of sort of rare events such as traffic accidents and risky lifestyle choices. And what you'll notice here is that the weights that people place on these different types of mortality risks vary substantially by age. And so the young place much more weight on these rare events than do old people, whereas old people put much more weight on medical conditions, dietary habits, and other natural course of aging type risks. And then what we did is we used the relative weightings that people place on the rare events versus other natural course of aging to see what effects this has on people's survival, optimism, and pessimism. And so what we found is that people who put their more weight on natural course of aging, and this is controlling for age here too, are more optimistic about their survival, whereas people who think about these rare events are very pessimistic about their own survival. So they basically overweight the likelihood of these rare events, and that guides their mortality forecasts. And so what I would think would be really interesting for the authors to do would be to run something where they don't ask the authors specifically about, they don't ask respondents specifically about their COVID risk. I would put COVID as sort of a part of a bundle of different risk factors and ask about their longevity, because then it would sort of get at, how much are they thinking about COVID and how versus other things. And this, I think, would sort of give a sense of whether or not COVID is top of mind to them. And I think would help support the salience interpretation that the authors have in mind. And the authors sort of do something similar to this, and I won't recap this regression table because Nicola did a great job of explaining it. But basically and so they have something that's really similar to this, but I think they could do it in sort of a slightly different way, sort of the way that I described from my own work. Okay, so the next thing that I want to talk about is one thing that comes to mind when reading the paper is it's sort of difficult to know what is the correct response, right? So you're always concerned in these types of surveys, and this is true in my own work as well, is that it's possible that the respondents actually have some, better information than you do, right? And so they know more about their own risks than the researcher does, and so they're actually maybe, calibrated in a way that you might not understand. And so so the paper benchmarks sort of loosely against true case fatality numbers, but I was sort of wondering, just in general, do these biases cause systematic inaccuracies in responses? And so earlier in the pandemic, myself and a few co-authors at the New York Fed put together like a short blog post about a supplement that we added to the May 2020 survey of consumer expectations. And so we were kind of limited in the amount of space that we could ask questions in it, because this is a lengthy survey already. But we were able to add a question about people's own risks versus others versus public health. So what we did, we were able to ask two questions here. What, in your view, is the % chance that COVID-19 continues to be an important concern for the public health in the US over the following timeframes versus you? And so we asked these two questions separately. And so our idea was sort of that if people are think that public health concern is going to be much larger than their own health concern, then it's going to be some sort of signal of overconfidence, that people underestimate their personal risks about catching COVID. And this is what we found over several horizons. So if you look on the right-hand side at these graphs, we found that by shifting away from zero, that in the positive direction, that means that they're more overconfident about their own personal risks relative to the public risks. And this actually sort of ends up converging once we look at 3 years out for forecasts of this. And we did a little bit in terms of assessing the heterogeneity of this, and including looking at the age gradient. And so we found that there's more confidence among college graduates and higher income individuals. And but we also added a information treatment about the 1918 flu second wave, and we reminding them that there was a second wave, because we surveyed people back during the first wave, even though in the US it's kind of been a perpetual wave. But we reminded people that it was going to be a long, sort of gave them a heads up that it could be a long time, and people became more pessimistic. But the one thing that we did find is that there was a little bit lower overconfidence amongst the older range individuals. So that age gradient had a negative coefficient. We didn't find any effects for local exposure. I'm not really quite sure why that was. But I think maybe it was just because the news was so prevalent that at that period of time when we surveyed people, that maybe everyone was sort of on edge at the point in time. But what's interesting is that the authors in the paper actually have a little bit that's comparable to this. And so what they can do is they could actually compare the beliefs about people like themselves, which is sort of their proxy for them, versus the beliefs about others. And it's not exactly correct because of the binning here, but it's really close. And what's really interesting is you'll notice that there's actually this overconfidence about people's selves in their survey too. And so I just loosely put the numbers from the second graph in the previous figure against the ones of the people like you graph in the left-hand side of the previous figure. And you'll notice that people are more pessimistic about the death rates of others versus their death rates of themselves. So I think that's really interesting, and it kind of has a level effect on all the responses in a certain way. It might not necessarily explain the age gradient, but it does sort of explain maybe where the levels are the way they are. Okay, so and the last thing I want to point out is, and this is unfortunately, I think it's something that my own work grappled with, and as well, and doesn't really have any way to address it, because we're doing this research at the present moment. I mean, it's hard to go back in time, and the Nicola and co-authors are also sort of have to grapple with this as well, and you wonder whether or not this is sort of an age effect or a cohort effect. And is there there's been a lot of think pieces about the current generation of youth. This is especially true in the US. I'm not entirely sure whether this is true in Europe, but there's all these think pieces asking whether, is there something about the current young generation that makes them so pessimistic? And so this is a great title, The Generation Wine, the self-pitying 20-somethings and the boomers who made them. And so there's some statistics that support this. And so they're, looking at time series evidence of mood disorders, seems to be, that the young people of the current generation are more susceptible to mood indicators. And now, and the same is true also if you look at suicides, unfortunately. So there's a higher rate of suicide death amongst the 20 to 24-year-olds in the US than there was in the past. One thing that I will caveat this with and cast some doubt on both of these figures is that I think that there's also a lot more acceptance of saying that you're depressed today than there ever was before, right? So it's not as stigmatized as it was. And so that helps explain a lot of the last figure, but it might explain a lot of this figure as well, because people might have reported accidents as opposed to suicides. So I don't necessarily know that this is true because of the way that the reporting bias might go, but I think it might. And so
Rawley, oh, very good. I was asking.
Yeah, there we go. Okay, so also one other thing I wanted to, I'm on the conclusion slide, but one thought that came to mind first thing this morning when I woke up, and here I'm on the US, so I didn't get a chance to change this and add this to the talk, is that there might be a little bit element of motivated beliefs when it comes to the older individuals. So one of the things that I've heard anecdotally a lot from older people that I know is they say, it's like, I don't have time to wait for COVID to pass, right? I'm already, I only have so many years left on this earth. And so therefore I'm not going to take the necessary precautions because I have to live now, right? I don't have much time. And so there might be a little bit of element of that motivated beliefs going on here as well. And I'd love to see somebody study that. So in general, I think that the authors are already planning to adopt a lot of this stuff going forward. And I'm really excited to see the next draft. And thank you everyone for letting me discuss this paper.
Thank you, Rawley. It was a very rich discussion. Nicola, would you like to respond?
Yes, thank you, Laurent. I'll go very quickly to leave some time for questions from the audience. Thanks a lot, Rawley. Please send me your slides, which contain a lot of useful information. And thank you for referencing your paper on longevity, which I didn't do. I did my presentation very quickly yesterday, and I forgot to.
Well, it's in the, you reference it kindly in the paper. So
yes,
so you can encourage people to go read the paper now.
Yes, that's right. Go and read the paper. And the next version will be referenced even better. But so I just let me say a few things. 3, okay? First, the elderly more subject to fake news, yet more calibrated. Well, we don't find that they're really better calibrated because they underestimate their own risk of dying quite substantially. Now, I don't know whether this is fake news or something else, and we will have some measurement to try to see that, but they're not so accurate. The second thing, I think you gave an interesting suggestion to say, suppose you ask about kind of our longevity question and then the risk of dying and see whether COVID comes up. That's a measure of salience of COVID. Now, that would be a bit of a different notion than the type of salience that we are accustomed here. The way we think about salience here is that there is a big shock like COVID that brings death top of mind to everybody, okay? That's how we think about it. And then the effect of this is going to vary depending on your reference. If you are someone, who's accustomed to being fragile, you maybe react to this much less than someone like a young person who is not normally entertaining the thought of dying. And, you know, of course, the fact that you read in the newspaper stories of people so young of your age who have died, despite the statistics, might induce an even larger surprise. So it's a bit different, but we will think also about what you propose. And the third point is overconfidence. Absolutely, you know, I did not emphasize, but we find this in our data as well, which is that people are less pessimistic about themselves than they are relative to others. And that's well known in psychology, and sometimes it's called overplacement, some other times overconfidence, some other times optimism bias, but you know, it's there.
Okay. Thank you, Nicola. Thanks. Now we have time for a few questions. I know Hector Calvo Pardo had some questions.
So Nicola, really nice findings, very provocative ones. And I had two questions. The first one is, so related to the sources of information. So how representative is your US sample by educational attainment? Because that could help a bit with trying to understand whether it is a misinformation effect or not. And also, it is important because I'm worried about words like COVID-19 in your questionnaire might not be understood by all of the respondents, particularly if the sample is aimed to be representative, right? So, and you know, since you seem to be fielding many surveys, many waves, one thing you could do to cope with that is to just change the word COVID-19 in 50% of the questionnaires and put instead coronavirus in the other 50% and see whether when collecting the data you see any differences between both, and then you're blinded against that. So my second question is more worrying concern, I think, because as opposed to asking about the stock market or inflation expectations or you know, firm profits in the aggregate, here you are asking about an endogenous risk, because your probability of infection and hence your probability of dying is going to be conditional on your own behavior. So there is this endogeneity here that may actually be consistent with what you find, because what we know is that the young, for example, do not protect themselves behaviorally. So they tend to expose themselves more, and hence consistently they should have higher probabilities of being infected. And you know, the old do the opposite. They shield as much as they can, and therefore they expose themselves much less. And they may think that simply, you know, because of their behavior, which is more protective, they have a lower chance to catch it. I mean, it is related a little bit to one of the Rawley's points, but not really, right? But I was wondering how could we think about this, where both, you know, these probabilities might be endogenous. So thank you very much. That's all I had to say.
Nicola, would you like to respond?
Yes, thanks a lot for the very good question. On the one, representative, is the sample representative on education? I don't know. I would have to check that. You know, it's representative with age, race, income, geography, but not and gender. But I don't know what this implies for education. We will check that. I mean, I don't know if the COVID-19 can be really misunderstood given the huge prominence in the media, but this is something, you know, that we can also check and validate. Endogenous risk and behavior, that is absolutely true for the risk of infection, okay? Which is in fact an outcome. In fact, we weren't surprised that with respect to the perceived risk of infection, the young, you know, have heightened perception relative to the elder. What we found surprising is the conditional risk of dying upon the event, is the risk of dying upon the event, conditional on the event of being infected. And in that respect, you know, there may be some, you know, behavioral factors playing a role there as well. I don't know if you're a young marathon runner and you get a flu, you just don't stay at home and take antibiotics, and you just expose yourself to that. But we think that this is relatively minor in the big scheme of things, relative, of course, to the risk of infection, which is much more subject to what you're talking about.
Okay, thank you very much. I think we're running out of time, but I think it was a very stimulating and interesting, an excellent seminar, I think, in discussion. And as we know, expectations is very important to all of economics. So, I mean, this is something that's go way beyond, I think, the current crisis, however important it may be. So the next seminar will be held on Tuesday, February 9th. Marieke Bos from the Stockholm School of Economics will present a paper on corporate restructuring and employees' mental health. And Paige Wimet from the University of North Carolina will be the discussant. So, we'd like to thank you for your participation in this seminar, and we look forward to seeing you in early February.